it matters in a sense if you want to try and match up to the labeling indications. And clinicians sometimes do and sometimes don't. But if one looks at what's done in clinical trials, that's of some importance. So like, for example, with siponimod, it was a study of secondary progressive MS, all secondary progressive MS. And they had a population that was very different than any prior relapsing remitting study, but they ended up getting labeled the same as all the agents that were initially approved for what was called relapsing forms of MS or relapsing remitting MS. And so there's a certain blurring of the lines between the characterizations. And so that has some implications, not so much for patients, but it makes for a certain lack of clarity of what your agent's going to do when you start to getting into, say, for example, treating patients with secondary progressive MS with activity. So I think we're pretty comfortable that those agents will have an effect on the activity they did in all of their clinical trials. What the effect will be on the underlying progression is not really clear beyond what we saw with, say, siponimod, because siponimod studied that population. Other agents have not.
And what considerations should be made from both a clinical and managed care perspective when it comes to optimizing treatment for patients with secondary progressive MS?
So optimization is a little hard. If you take, well, as I said, with the other agents, no one else has really looked at this population other than it's a subset of the group that was studied in the siponimod studies. And so this is something we're going to have to look at and see. I don't see it being studied again for the agents that are already out there. It theoretically provides a nice framework for new studies moving forward of other agents. And I suppose existing agents could also, if they wanted to, try and do this. But studying secondary progressive MS is difficult. It's difficult because, as opposed to the studies done in primary progressive MS, the secondary progressive MS patients have had their disease for a longer duration. And so we've had studies, for example, of natalizumab, which didn't succeed in secondary progressive MS. But again, it's a tough bar. It's a difficult hurdle. And so what's in the label now is secondary progressive with activity, but no one has set out to study specifically that population. And so I think it's going to be up to the clinicians to try it when they think it's appropriate for their patients. Certainly patients with a lot of activity would perfectly appropriate for any of these things. But there is an information gap here of actually looking at that group of patients, secondary progressive with activity, with a defined measure of activity. And so, like I said, if we were doing it, we would say the secondary progressive activity would be a patient who either had a relapse or new lesion on the MRI scan over a period of, say, 1 year. But one could go ahead and use anyone's definition if you just wanted to use the way the FDA was leaning and say, okay, let's just study secondary progressive patients who have had relapses in the past year or the past 2 years, and that becomes your study population. And that's okay, but it doesn't get to the issue of how best do we treat progression. And that's a major unmet need of ours because at best, those therapies that have succeeded, it's been quite modest.